I'd like to thank the moderators for inviting me and be talking about endoscopic liner therapy and ablative treatment for obesity. Here are my disclosures. For bariatric surgery, this was talked about earlier, we have medical treatment, we have surgical treatments, and in the middle, I think, is where the sweet spot is going to be for endoluminal therapies. To discuss those that exist, the Endobarrier is a duodenal jejunal bypass. It's endoscopically inserted as well as removed, positioned in the bulb of the duodenum, and the sleeve extends past the ligament of Treitz. It's a fluoropolymer sleeve, nitinol anchored in the bulb of the duodenum. It's clinically been used in Europe, South America, and the U.S. Pivotal trial is currently halted. However, I think that it will come back once some of the issues have been sorted out. The results with it are actually impressive. This is a multi-center randomized controlled trial done in Europe. 38 patients randomized to sleeve, and of those, 34 were implanted. 12-month studies showing dietary intervention with 6 months of the bypass liner in the study group. The initial BMIs were comparable between the two groups, and weight loss was substantial. At 6 months, 32% excess weight loss in the liner group compared to 16% for the controls prior to explant. At 12 months, so the follow-up beyond the explantation showed sustained weight loss, and you can see in the bottom with similar metabolic parameters. It also has demonstrated significant improvement in diabetes, and here is hemoglobin A1C. Changes over the duration of the therapy, and on the right-hand side of the screen, concomitant decrease in medication usage between the two groups for the sleeve or the liner as well as the control patients. The device that at UCSD we've been involved with for now about 10 years is a gastroduodenal jejunal sleeve. It's anchored at the gastroesophageal junction. Initially we had combined delivery, now it's completely endoluminal, and so truly incisionless, with the idea that it mimics restriction and duodenal and jejunal bypass that we see with a RU. The pilot study results were published in 2011 and 2015, and these showed durable safety and up to 1 year implantation with 42% excess weight loss at 12 months. Comorbid condition improved across the entire spectrum, so type 2 diabetics showed an average improvement in their hemoglobin A1C of 2 percentage points. Fasting glucose improvement of 43 milligrams per deciliter with resolution in your other associated comorbid conditions as well. The current device, as I said, is endoluminally placed. The cuff is retracted after delivery hydraulically of the sleeve. The cuff is retracted to the GE junction, and transmural anchors are placed. Here you can kind of see a quick little cartoon of how it looks. This is the endoscopic image once the 8 anchors are sutured in place. And here's actually a video of the device of us placing it. We start with tattooing of a point 2 centimeters above the Z line. So that's our target for suturing. So we want to visualize those tattoos as we go down with the device. And here you can kind of see what the marks look like once the tattooing device is removed. Here's our cuff once we've delivered the sleeve and retracted the cuff back up into the esophagus. Now we're down with the suturing platform, and here you can kind of see the control of the suturing platform as well as then the targeting of the tabs for this for the device. Once we capture each of the tabs, which is shown here, we line it up again with the previously placed marks so that we know we're at the 2 centimeter point above the Z line, and then go ahead and fire the needle. The placement of the needle is done with vacuum application, and currently we're modifying this device a little bit further to actually a forward-throwing suture without some of the challenges you see here. This is the previous generation of the device. Once we've got the tab captured, the needle in place, now you'll see we pull the scope back, pull back the guide, which is in the bottom right-hand corner of the screen, actually then apply the vacuum, and you'll see the screen kind of blur and fire the stitch. So here we are, just about ready to apply vacuum. The vacuum is controlled via pump, so it's actually a deliverable, consistently deliverable pressure that we monitor via the pump on the back at the head of the bed. As we do this, we rotate around. In this device, it was 8 sutures that we place. Following this, patients are kept overnight in the hospital. Here's a image of the swallow study that we get, which we like to, in this early phase of the study, make sure that we don't have problems with leaks or anything like that. We've not had any of those. Here are some of the results. So it was, with this trial, 32 patients were implanted endoscopically, 24 female, 3 different clinical sites. Average preoperative BMI was 42. Mean follow-up was 12 months. Of the 32 patients, 28 achieved the 12-month follow-up with the device implant in place. 100% procedural success, meaning we were able to place it at the time. At the 12-month period, mean of 45% excess weight loss, of 17% total weight loss, and you can see the comorbid condition improvement as well. This is an aggregate of all patients in the trial and their weight loss curve over the duration of the device looks similar to weight loss surgical procedures. We broke out patients that had complete capture of food, and we actually found, as we would expect, in the bottom right-hand corner, that subgroup analysis showed when you have complete capture of a food bolus, you actually have improved weight loss. So the device actually seems to be contributing to their weight loss. As some of the devices progress in the patients, some of the anchors become a little bit detached periodically, and so those patients had less substantial weight loss. The other device that I was asked to talk about is the fractal device that Dr. Kurian had mentioned earlier. So this is endoscopic duodenal mucosal resurfacing. This was discussed and first presented in Montreal. It's a procedure that's in development in Chile, and it is a 2-step endoscopic hydrothermal ablation of the duodenal mucosa. The idea is that it helps eliminate the duodenal mucosal surface as an absorptive surface for nutrients. Here's a cartoon of the procedure. So the ampulla is visualized, and a balloon is then passed beyond the ampulla. The submucosa is injected to lift the mucosa away from the wall of the duodenum, so that when they apply the thermal energy, they don't suffer full thickness burns. And so this is 3 needles placed in a 120 degree angle around circumferentially, so that you get circumferential saline lift in the duodenum. Once the lift is performed, here you can see the assessment of that lift. Then the second step of the catheter, the second step catheter is placed, and this is actually the energy delivery catheter, which is done through a again, over a wire through the scope. And here's a picture of that being placed. The delivery energy is then applied, and that is meant to heat up to about 97 degrees Celsius, so enough to denature proteins on the mucosal surface. The enrollment criteria were diabetics of less than 10 years duration, ages 28 to 75, hemoglobin A1C, so relatively poorly controlled diabetes, no previous bariatric surgical procedures. Here you can see it's a 3-year study. 30 patients were enrolled, 8 of whom were female, and you can see the parameters procedurally for them. They had long and short segment ablation, and that was, again, because this is a first-in-man trial. They had some just technical issues with the length of ablation they were able to achieve. The long segments about, on average, 9 centimeters of ablation, and they had better weight loss with the longer ablational therapies. So, and hemoglobin A1C similarly improved. So, again, adverse events with this, they had 3 patients that had duodenal stenoses that were treated with balloons, but other than that, no other surgical interventions and minimal other sequelae. So anyway, that's that's the end. So I just want to thank everyone for the opportunity to speak.